Thank you very much. And just want to say that this part of the evening is going to be kept fairly short. People are going to be filtering in because I understand that there's a real traffic problem out there. So expect a few people to walk in during the presentation. We'll try to keep it short. We promise to keep it under 30 minutes so that we can spend the rest of the time talking, eating, and drinking, if that's all right. Also have some books here that we brought in that you can purchase if you'd like, well below the usual price. And that is because the publisher is not directly involved in the sale of these books today. So been able to do them at a bit of a discount. At any rate, the title of this, Understanding the Boundaries of Medicare and the Canada Health Act, can be a little misleading because what we're really dealing with are the various services that are, in a sense, parallel or substitute for the Canada Health Act at various times. And I just want to say that the reason that we did the book, and I want to acknowledge Katherine Fierlbeck, because it was her actual idea to do this book. She talked me into it at the very beginning of the pandemic, and we decided to work together on it. But for some time, she had been trying to figure out these exceptions to the Canada Health Act, which confuse a lot of people, providers and patients. So that was the original motive behind the book. And the structure of the book is to deal with what I call the carve-outs of the Canada Health Act, in particular, workers' compensation, the Canadian Armed Forces, inmates and federal correctional institutes, as well as some fill-in services for migrants, particularly political refugees and migrant temporary workers in Canada, and then deal with a parallel area of services for First Nations and Inuit, probably the least understood area. And then finally, an area which has created a fair amount of conflict, particularly during the pandemic, and I would say some very public confusion as well, and that is the area of virtual care. But the first thing I want to do is just situate, before we talk about all these exceptions to the Canada Health Act, to talk about the Canada Health Act itself and what we mean by universal health coverage in Canada. And I always liken this to a three-layer cake. And if you look at the Canadian health system, you can see that these three layers can be distinguished in terms of the services they cover, the way in which they're financed, the way in which they're regulated and administered, and finally, the way in which they're delivered. And so I never talk about the Canadian health system per se, because I think it's important to situate universal health coverage within that. It's not the entire system. In fact, based upon some very rough estimates, it's probably not much more than about 42% of the system. The rest of the system falls within the mixed and private categories. So looking at that Medicare layer, I just want to point out that the most important aspect of that is it has all of these characteristics that separates it from the other two layers. But there are certain aspects of it that are not common throughout the country. Every province has its own set of laws, regulations, and policies concerning Medicare. And this makes for some slight differences depending on where you live in this country. And we have a tendency, of course, to always look at Medicare through the province that we're most familiar with. And we then apply that to the rest of the country, but that can be very dangerous at times because it's not the same throughout the country. In terms of the Canada Health Act, which was established in 1984, it was built upon two previous laws that basically provided most of its content. But there were a couple of new things. And first of all, Section 12 on accessibility was new. And that was to ensure that there wouldn't be anything that would be done to basically prevent people from accessing services based upon finance. And this finds its real sort of where the rubber hits the road is in terms of Section 18 on extra billing of physicians and Section 19 user charges by hospitals and other facilities. And basically those require the federal government to deduct dollar for dollar the amount that any provincial government allows in terms of extra billing or user charges. This is what it looks like when you look at an organization chart for the country. It's highly simplified, but you can see that while the Canada Health Act is within the responsibility of the federal government to enforce, that most of the heavy lifting in terms of Medicare is, of course, on the provincial side, and it's actually administered by provincial and territorial health authorities, whether you're talking about Ontario Health in this province, or you're talking about regional health authorities or single provincial health authorities in other provinces. The mixed layer, the only reason I want to emphasize this is because this mixture of public and private financing, while it's important, it obscures something else that differentiates this from universal health coverage. Virtually all of the services that fall into that category that are subsidized or partly funded by provincial and territorial governments are not provided on a universal basis. They're generally targeted either by population or through the use of means tests, etc. So it's very different than universal health coverage services. The private layer, well, as we all know, that there's been some changes in dental care in the last few months, and it's slowly migrating from the private category perhaps to the mixed category, although it's very gradual at this point, so I haven't moved it from this slide yet. We talk a lot about access rules in this book, and that access rules are simply the rules about who is covered, what services are covered, and what proportion of costs are covered. And every time you look at a particular area, you need to find answers to all three of these questions in terms of the access rules of coverage. As to why we did this book, I can let Katherine in a second speak to that more, but these are the least understood areas of Medicare, so we decided to shine a bright light on them. We wanted to figure out with some degree of precision of who's in and who's out, what's in and what's out in terms of services, and the respective federal and provincial roles in each of these carve-out areas. We also wanted to understand what are the challenges that are faced by both patients and providers in these areas. And I don't know if anyone here today is a doctor, but doctors deal with this all the time, and their offices generally have different methods of billing for different kinds of patients or for different kinds of services. So they're familiar with sort of the mechanics of it, but without understanding why there are these exceptions in the first place. We're going to start with what is in fact the second chapter in the book, which is workers' compensation, because of some very purposeful misperceptions about it being some kind of private tier, when in fact it is actually a separate public tier of Medicare. Katherine?
Thanks, Greg. So yeah, again, this project began, as these things often do, with a graduate seminar where I was trying to introduce a unit on Indigenous healthcare. And when I started looking at it more closely, I was rather shocked at how much I'd got wrong. And as I looked at it a little bit more, I was shocked at how much other people were getting it wrong as well. And as I did even more digging, I was shocked still more to see how even patients and providers involved in some of these areas really didn't have a clear grasp on how some of these programs worked. So workers' compensation is, in fact, one of the most clearly set out. And the chapters in the book formally are ordered according to how they are referenced in the Canada Health Act, however obliquely. And workers' comp here is first up, but it is also somewhat coincidentally one of the oldest programs, starting, as you can see, in about 1914 in Ontario. And at the heart of workers' compensation, it's really important to understand this politically. At the heart of workers' comp is what's called the historical compromise or the historical compact, wherein injured workers essentially relinquish the right to sue their employers. In exchange for that, they get a fairly stable and predictable system of compensation of injured. And often, workers' comp is referenced as a separate system working in parallel with Medicare, but really that's not quite accurate, because workers' comp, to the extent that it used to have discrete treatment facilities, now really depends heavily on provincial systems to deliver the care, which is paid for via workers' comp funds. The problem is that things really started getting out of whack in the 1990s when, for various reasons, provincial healthcare services became more difficult to access, as we well know today. And of course, every day that an injured worker sat injured, the more workers' comp had to pay out for them. And the longer it took an injured worker to get treated, the less likely they were to recover, which meant expensive permanent disability costs. So to get workers treated quickly, workers' comp started routing them to private services or provided premium remuneration to be seen more quickly in the public system, leading, of course, to the claim that this was highly unfair to those in the public system who had to wait longer to be treated for the same conditions. Now, with workers' comp, the possibility has been raised since then that workers' comp should simply be folded into the public system. But, as long as there are wait times, and I think we can expect wait times to be long for a while, this means higher costs for workers' comp, and the premiums paid by employers will be high if they are limited to the public system for this reason. And so employers will, because of this, be more inclined to ditch the workers' comp system if they have to go through the public system, leading back to a scenario of unsupported injured workers and costly litigation, neither of which anybody really wants. So those are the dynamics essentially of workers' comp.
Okay, the next is the Canadian Armed Forces, and it truly is the 14th health system in Canada, and it's unlike workers' comp. You can consider it a parallel system. It serves about 70,000 active members, and in garrison care, that is care within Canada, is done through Canadian Forces Health Services Group, and they provide all primary and most secondary services. But tertiary acute services are generally contracted with various provincial governments. At one time, the federal government military used to have hospitals, but those have been closed down. Basically, the last one that was operating, I think, was in the 1990s. And so today, all of those services are contracted out. The clinics across the country are one thing. The individuals that work within those clinics are really in training and preparing for conflicts outside Canada so that they can be sent to conflict zones on very short order and provide a full range of services, including many acute services in these conflict zones. And that is the reason that there is this separate parallel system. And if you look at most other countries, they too have a military health system. One of the differences between Canada and the United States, for example, however, is the fact that members of the family are not included. Why is that? Well, partly because we have universal health coverage in Canada, unlike the United States. So family members are covered under that system, but the active member is covered under a separate system. But the moment that the active member of the Canadian Armed Forces retires, they then go under the provincial system. And veterans benefits do not deal with Medicare services. Veterans benefits are all about what we would call the categories of services in that mixed category: long-term care services, home care services, some rehabilitative services that are not considered part of Medicare, et cetera. So it's a very different category and should not be compared to Medicare at all. Katherine?
Right. So here's one of those great Canadian subjects where federal and provincial jurisdiction becomes really messy. Because while provinces have authority over jails, Ottawa has jurisdiction over penitentiaries, which house inmates serving sentences over 2 years. And of course, provinces have formal jurisdiction over hospitals. So historically, we have cases where violent psychiatric prisoners were tossed around like hot potatoes between federal prisons, which weren't really set up for mental health treatment, and provincial psychiatric hospitals, which weren't really set up as secure facilities. Um, Penitentiaries have their own in-house system of healthcare to a limited extent, although they contract out much treatment to provincial facilities. Soft law measures expect that healthcare provided in prisons should be up to the standard provided in provincial health systems, but things such as wait times vary so much. It's kind of difficult to determine whether delays are due to ongoing pressures within a provincial healthcare system or maybe to the intransigence of prison authorities. So it's very difficult to unravel that. Interestingly, in half of Canada's provinces, the healthcare in provincial jails is provided directly through the departments of health rather than justice. And then the other half is just the opposite. And moreover, in many other countries, such as Norway, France, Australia, Italy, England, Scotland, prison healthcare has really now been transferred directly to the healthcare system. So it's not mediated by the prison system anymore. And so the question naturally becomes, well, why can't this be done at a federal level in Canada? And interesting questions arise here that include, do prisoners have any charter rights to the level of healthcare provided to other citizens? And are federal prisons ultra-virus if they run psychiatric hospitals within federal penitentiaries? So a lot of interesting jurisdictional issues come out of this. And so migrants, this was one of the most complicated systems to explain simply because there are just so many different classifications of migrants, each with their own pathway to healthcare. And so we look at two of them in some detail. The first category we look at are temporary foreign workers, so mainly in the food sector. And the problem, again, is that each work program is slightly different in terms of the length of time, who is eligible for healthcare, under what terms. Each province has different stipulations for access to provincial health services. Private health insurance is usually required, at least until the waiting period to access provincial care has elapsed, whereupon they're again covered by provincial insurance. Keep in mind that as Immigration Canada has a say over these programs, the federal government is involved here as well. And also, if a temporary foreign worker gets injured on the job, workers' comp also is a player here. So there's an awful lot of moving parts. And on paper, it seems like it should work well in terms of coverage, but in practice, there are all sorts of reasons why temporary foreign workers cannot or will not access services for which they're eligible. The other category are humanitarian migrants. Generally, we call them refugees, and most refugees are eligible for federal support through the interim federal health program. But again, there are several different streams of these humanitarian migrants. And so the kind of support that they receive is slightly different in all these different categories. Now, in 2012, the Harper government, under Jason Kenney, I think, who was the minister at the time, sharply limited access to these benefits, stating that refugees should not have better access to healthcare than Canadian citizens. So in some, I think there are 11 different categories of refugees, and for some of these categories, technically, a refugee, say, having a heart attack was not insured under these changes. Now, of course, at that point in time, usually provinces stepped in to fill the gap, or even hospitals just said, yeah, use the emergency ward. But this policy change led to a largely successful legal challenge, which was followed immediately by the election of the federal Liberals back in 2015, who changed things back again, which was fine on the face of it, except now there was massive confusion regarding who was eligible for what the payment systems were. And so often those eligible for services either didn't know that they were, or else providers refused care because they didn't know how to access federal payments for these services, which admittedly were often quite cumbersome. And the interesting political point here is that because the interim federal health program is determined through orders in council rather than through legislation, it's very vulnerable to becoming a political football. So keep your eyes on this program if the federal Conservatives form the next government, because that might be interesting. Greg.
Thanks. Well, now and get into a very contested area of Indigenous health. And the first point I want to make is that both First Nations and Inuit are not excluded populations under the Canada Health Act. This goes back to the 1950s when the federal government first negotiated national hospitalization with the provinces and basically insisted that they had to include their Inuit and First Nation populations within their definitions of resident, or they wouldn't get cost sharing. And the provinces contested that at the time, but ultimately lost the argument. That was then carried over to the Medical Care Act of 1966, the negotiations that led to that. There was again an effort by provinces to have First Nations and Inuit excluded that failed. The federal government insisted that they weren't going to make that size of investment in Medicare unless the provinces included their First Nation residents as well as Inuit. So that's the history behind that. So you would think, well, everything is fine then, it's very clear, but it's not very clear because there were many areas in certain provinces that were underserviced, that had previously had federal nursing stations or what were called Indian hospitals. And those remained in place until some way could be figured out on how to provide services to those populations that were very geographically separated from services. To this day, there are hardly any hospitals on or near what are called Indian reserves under the Indian Act. And it's mainly because at one time that was considered to be something that was entirely the responsibility of the federal government. So you had this ongoing issue. Now, we no longer have so-called Indian hospitals. Those are now either been torn down or have been transferred to provincial governments. And we no longer have many federal nursing stations, although a few still exist, even though the provinces and territories clearly have the responsibility to provide Medicare services. So it remains a somewhat confusing area. But what is probably most confusing is this whole thing called non-insured health benefits. And yeah, I think it's well named because non-insured is a direct reference to the Canada Health Act and insured health services. Non-insured services are those that are outside the purview of Medicare. So very similar to what I described earlier with veterans, it's those kinds of services, prescription drugs, long-term care, home care, etc., that are the subject of non-insured health benefits. The access to these, of course, they're largely administered by the federal government, but there are exceptions. And this is where the responsibility and accountability has been transferred to Indigenous governments and organizations for the administering of these services. And I just want to quickly go through some of the examples. The biggest example is not on this list, and that's the government of Nunavut, which was created largely as a Inuit self-government, although with a mandate to provide services to the entire population. Approximately 80% of the population is Inuit, 20% are others, and the government of Inuit provides services to all. But from that perspective, you can see that as, in a sense, an Indigenous health system. These are the small islands within provincial health systems in which you clearly have responsibility for the administration and delivery of Medicare services by these Indigenous governments and organizations. This was done after an extensive survey of what had happened in the country over the last 40 years and what exists in terms of services on the ground. Virtual care. Now, there's a little bit of a problem I want to mention right at the top. Virtual care can mean virtually any kind of care, but it really shouldn't. It can be any kind of information communications technology, but our image is not that of a telephone. And yet a lot of the virtual care that's delivered in this country is by telephone, particularly since the pandemic, when the provinces changed the billing codes in all the provinces to allow for payment of services that were delivered over a telephone. What I'm really talking about, however, here are the services that are provided in a more extensive virtual care platforms. And that is generally what we would automatically think should be a virtual care services. In other words, something that's interactive, in which patients and providers see each other, in which information is actually exchanged, in which there's some capacity to provide, for example, chart transferring and that sort of thing. Now, during the pandemic, people who did not have a family doctor and couldn't get appointments in at least some provinces began to rely on private virtual care services. And there was this huge conflict, province by province, as to whether to bring those services into Medicare or not. Clearly, they were medically necessary services, generally primary care, but some secondary care, some specialized care. And some provinces very quickly moved to bring those services in, others resisted. And it created a real issue in the country for some time. Now, Section 12 of the Canada Health Act states that the provincial and territorial Medicare plans must provide for insured health services on uniform terms and conditions and on a basis that does not impede or preclude care. Now, that means that these services probably should be within Medicare, but we haven't yet sorted this out, and it's going to take some time. And part of the reason it's going to take some time is that there's a real cost impact in terms of provinces, and there are many commercial companies. These are examples of private for-profit companies that are in the field that are very much looking for public subsidy and want to be part of the system because it means a lot of money. So we haven't sorted this out. There are very few what I would call private not-for-profit or public alternatives to these companies in this field right now. So most of the provinces have decided where they want to include the services is to, in fact, pay these companies. Sometimes it's not a payment that's made to any company that provides the services, but they decide which companies are going to be preferred suppliers, if you like, and those companies are then included in terms of Medicare and the funding system for it. Katherine, I'll let you end on final observations.
All right. So as Greg outlined in an earlier slide, the structure of the book begins with clearly delineated exclusions from the Canada Health Act. And then we sort of end up with conflict and confusion. And the point that I want to leave you with is that these fuzzy boundary areas are actually becoming more pronounced, and we really have to pay attention to them and focus more sharply on them so that we can understand how healthcare is I think, shifting under our feet. Now, the focus in the book has been on public services outside of the Canada Health Act, but the dynamic tension we see evolving is that public services once firmly within the Canada Health Act are now increasingly being situated outside of the Canada Health Act, leading to the rise of duplicative care in many instances. And of course, virtual care is a perfect example of that. And again, some provinces now allow virtual care to be provided by those licensed and living outside of a province, which makes it increasingly difficult to keep tabs on it, especially if provided privately. And in fact, last summer, as part of my field research, I was able to access primary care from a GP in Pakistan on an app, and from her got an X-ray requisition that was routed through a doctor with an office in Toronto, all with my healthcare number. So, there are a lot of interesting things happening, little loopholes opening, and I think health insurers are really having to pay whack-a-mole trying to control all of these things. But, virtual care is not our only concern here. Health services are increasingly being provided outside of the context of hospital care. And in that way, considered by provinces often to be outside the parameters of the Canada Health Act. So the dust up over medically necessary diagnostic services this year was one example of that. And I can tell you that despite the penalties imposed on Nova Scotia, for one, Nova Scotia is still allowing private clinics to provide these diagnostic services privately because they are not happening in hospitals. Health services are also increasingly being provided by healthcare professionals other than physicians. Many professions' scopes of practice have increased exponentially, certainly before COVID, but also driven by COVID, especially pharmacists, paramedics, but most of all by nurse practitioners. And the number of nurse practitioners in Canada has exploded. It's doubled between 2012 to 2020, and in fact, rose another 11% in the last year alone. And the scopes of practice for nurse practitioners in many provinces is getting increasingly close to that of GPs. And because some provinces define insured health services as services provided by physicians, for example, nurse practitioners can provide pretty much the same services as GPs, but what they provide are not considered to be insured services as they're not provided by doctors, which is why so many new private clinics are run and staffed by nurses and nurse practitioners. So the fuzzy boundaries between CHA and non-CHA services, I think, are now becoming, if you will, liminal zones where public services become private services simply because of where they're offered or because of who's providing them. So, in other words, we set out to establish clarity, but I think rather than simply clearly explaining the problem here, we've really realized that the situation is becoming rather more complicated than we first anticipated. But I think the only consolation to that is that this is a great launching point for all sorts of questions that folks might have.
Thank you, Katherine. Well, on that, I think we can open it up to questions, and then we can, when the questions are done, then we can begin to have fun. But please, let's, who would like to ask the first question?
Hi, I was just wondering does the focus come on hospitals? Because really the number of us that require hospital care, well, none of us want to be there for one thing, unless we have a traumatic incident or an emergency or require surgery. Where does the focus on hospitals come from? Because they aren't the biggest provider of healthcare by any means. We're always talking about money for hospitals.
Yeah. It's the way in which universal health care is defined in the Canada Health Act. And the definition for hospital services is very comprehensive, but it's based upon a history where most things beyond primary care were provided in the hospital. And we haven't moved away from that definition. And if there was to ever be a rewriting of the Canada Health Act, that would be one of the key areas to begin to revise quite substantially, because we're very different in terms of the way services are delivered today than we were 60, 70 years ago with the Hospital Insurance and Diagnostic Services Act, which was then the same definitions were put into the Canada Health Act in 1984. Katherine?
I can't add to that, except to say that I think in terms of cost, hospitals are still the highest, the biggest area for costs for provinces, if I'm not mistaken.
Yeah, that is true.
Well.
Yeah.
Exactly, people don't need to be there. Well, why would you go to the most expensive area for care when you don't need to be there? That's part of I think that's part of the big problem with the funding.
Yeah. Although the one thing is that I think that some of the outpatient services provided in the hospital may not be sort of calculated in that way, but whether they are or they aren't, we get your point for sure. Was this all too confusing? All these exceptions to the Canada Health Act? Yes.
I'm sorry if this is not a well-formed thought, but you mentioned that it was kind of in the discussions in the 60s that the government really insisted that First Nations and Inuit people be included in the PT healthcare.
The government of Canada, yeah.
Sorry, yeah. Is there a reason beyond just funding? Were they interested in efficiency and having a greater population of people or a greater number of people under one plan? Or was it simply just, we don't want to?
Oh, that is such a good question. I've been trying to get at the answer to that for about a decade, and I haven't been able to get at it. I have gone through the records of the time to try to understand what the motives were. The only motive that I could see firmly established was that the federal government did not want to have the cost associated with that go on forever. And they thought that by transferring it to the provinces would reduce their responsibility and cost. But there's also some indication that there were some individuals in the Department of National Health and Welfare that were promoting this so that they're in fact, first of all, that everyone will be treated equally in a sense. But second of all, that Indigenous people would receive the same quality of treatment, because at that time, it was well understood that Indian hospitals were an inferior form of treatment and quality of care compared to provincial hospitals. So they wanted that to end. But I haven't got to the bottom of that. It's only an indication.
I actually, to follow up on that, I have a question for Greg myself. And I started this whole project trying to figure out Indigenous healthcare. And it's only become, I think, more complex and more confusing to me. So these new Indigenous health authorities, Greg, are they funded? Are they funded directly from federal monies, or are they funded directly as, are they funded by the province, or is it some combination thereof? How are they funded?
It's a combination. You noticed in that chart, I looked at there were a number with tripartite agreements. Whoops, right here. These framework agreements basically set out what the federal government will pay, and that's generally for non-insured health services. What the provincial governments will pay, which is actually insured health services. They're responsible for the Canada Health Act services. And then what the responsibility of the Indigenous government or organization is in terms of the provision of services. And it gets, there are some difficult areas, mental health and addictions, because that straddles what I would call Medicare services and non-Medicare services. And in those areas, because the federal government has always played a fairly major role in population health, and in initiatives that have funded community-based efforts in this area, the federal government generally puts in quite a bit of money for those sorts of things. So that's one of the complicated areas for sure. NIHB has been a difficult one because when it's transferred, but with all of the rules and regulations in place. So there's not much flexibility that's given to the Indigenous governmental organization in terms of who's eligible and who is not eligible for NIHB services. And just as an aside, this created a real issue in Nunavut because 80% of people were receiving NIHB benefits from the territorial government, which had been, in a sense, empowered to do so by the federal government. That left the other 20%, and that other 20% was so upset about the difference in terms of benefits that the government said to heck with it and basically provides the equivalent of NIHB benefits to the entire population. Now, they would have had to have gotten consent to do that, but no doubt the federal government said, we're not going to pay for that. That's something you have to pay for and figure out how that's going to have to come out of your own source revenues. So I'm sure that that's what happened. I have a little bit of evidence on that that tells me that that was exactly the agreement, but these agreements are notoriously difficult to get a hold of. Yes.
So I'm particularly interested in the issue of reproductive services and healthcare, which I realize is not part of the areas that you were studying. And I was wondering if you could discuss just briefly the funding and how that's really an exception in some ways.
Yeah. That was a contentious area. It's a little less contentious, except in a couple of provinces, but basically it was brought within the purview of Medicare in most provinces. It was considered to be one of the sort of areas, what we call gray areas, but most provinces decided to make it part of Medicare. So it operates under the rules of the Canada Health Act. The federal government did not get directly involved in determining coverage. They left it up to the provinces. Most provinces decided that it's medically necessary and therefore services need to be provided on a universal basis. And it doesn't matter whether it's provided by a private clinic, through a public hospital, or a public entity. So it operates under those rules. Yeah.
A concept that Katherine mentioned that struck me was sometimes with these policy changes in healthcare, they would play like football with it. And I was reminded of like the Jordan's principle when they couldn't decide who was going to pay for the child's healthcare, and so they just kept bouncing it around. How does that impact our general like public healthcare? And if we made the conscious decision to just include everyone, as opposed to dividing it into these different subsections, would that benefit us in any way, or do you think these subsections are required?
Okay, well, Katherine, do you want to respond to that first? Did you hear
No,
the question?
I couldn't hear it. It was the sound was garbled, so I couldn't follow that.
Okay, I will take a first stab at it and I'll sort of repeat the question then. The first part of the question is disputes, continuing jurisdictional disputes as to who is responsible for what, and the end result is that patients do not get the care that they need despite mechanisms that have been put in place and agreements like Jordan's principle, et cetera, where the governments are supposed to act immediately and then figure out who's responsible for the financing after. And this, of course, is continuing to be an issue. And then the follow-on question is there some way to avoid this? And I'll start with that. I doubt that very much, simply because we live in a highly decentralized federation where there are always going to be two orders of government with two levels of responsibilities. But even more complicated, we have really a third type of government that has emerged in the last 40 years. Those are Indigenous governments, and they would not agree to have a single provincial or the federal government manage it either. They want to be able to have the responsibility and the control within their communities. So we're going to have to work this out in other ways, and it's not always particularly easy. What you don't hear about are all the times that this does get fixed. And actually, given how decentralized the Federation, it's a wonder that things work as well as they do at times. Now, I don't want to be overly simplistic about this, because there are huge problem areas, and Indigenous health is certainly one of the areas where we've had the most problems in this area. The other thing that the exceptions raise is the confusion among providers who are responsible for providing those services at the front line. And they don't know. They don't know who's paying for this. They don't know who they're going to send their bill to. They don't know what to do. They don't know if a government has said, you can't serve this person even. So sometimes they simply refuse the service, which is, it's obviously very detrimental. So, we have a long ways to go here. And these exceptions really raise some of these issues. Migrant farm workers, that has been a hugely contentious area in this country. Katherine, do you want to?
Yeah, I mean, the problem of cost shifting, where each government tries to push the costs onto another, is very, very prevalent. It's not just Indigenous healthcare as well. There's the example of the RCMP, where it was just the feds gave it up and just said, no, the provinces can cover it. And of course, there was the example of refugee claimants as well, which was a huge kerfuffle for a few years. And I think another area currently that is really being under-examined that I find absolutely fascinating is, again, medically necessary diagnostic services, which the feds say must be covered by the provinces, and the provinces say, no, we're not going to do it. And so keep your eye on that to see where that's going to happen. And I think we really haven't seen too much of this in the past 10 years, simply because the government that exists is the federal Liberal government is one of their raison d'etre is to open up coverage and to, in terms of refugees, in terms of Indigenous. So they've been, trying quite hard to be inclusive. But if this regime is coming close to an end, then I think we can see a little bit more fraught debate over this issue of who covers what coming up in the next 10 years.
Thanks, Katherine. Any other questions? And it doesn't have to be about the exceptions, and it can be about Medicare more centrally, if you like.
I think there might be one in the chat,
All right.
but it's long. Here.
Oh, it's a speech.
I'm not sure if this is a question or a comment. Yeah.
Okay.
Go to the last
My
slide.
goodness. How about I'll start with the first question. Can you talk a bit about the interprovincial reciprocal billing agreement for physician services as it pertains to virtual care? If you need more elaboration, I can dig a bit deeper into the question, but.
All right. Well, Katherine, I'm going to let you come in on this after, because it's something that, again, I grappled with this. But the reciprocal billing agreements, the way in which they're supposed to work is that any medically necessary service is automatically taken care of by the province with, which you're a resident, no matter where you are in the rest of the country. And you as a patient never see this, but there's all this machinery in the background where provinces get reimbursed for services that they provide someone who's not resident of their province, but from somewhere else in the country. There are a couple of exceptions. One of them is in medical care services. This started with a dispute between Ontario and Quebec, and so there's no effective reciprocal billing agreement on medical care services, not on hospital services, but on medical care between Quebec and Ontario. And that over the years has been, in a sense, furthered by other disputes with other provinces in the province of Quebec. So we have an issue there. And what causes these disputes is that when there is a fundamental difference in the billing rates in provinces. And in Ontario and Quebec, there was up to a 30% differential between what physicians were paid in Ontario, what they were paid in Quebec. And the Quebec government initially said, well, we'll pay at our tariff, not at the Ontario tariff. But even that became extremely difficult in explaining this to their own residents. In some sense, it was easier just to cancel the agreement. You see that in other provinces now too. And I've seen that in myself walking into large clinics where this has become a major issue. When it comes to virtual care services, that raises a hornet's nest of issues, in part because the providers are not going to be registered in your province or registered maybe in the province which you are providing payment back to. And then that, in a sense, can lead to further disputes. But again, the provinces have set up technical arrangements and committees to be working on this. And I presume they're trying to figure out these arrangements and trying to amend the reciprocal billing agreements to deal with virtual care. But I have no idea if that work is going on right now. Katherine?
No, nothing to add to this one.
Yeah, that's a tough question.
Karen, does that answer your question? Sorry, Karen, does that answer your question?
Yeah, thanks. I mean, it raises the question of where is the practice of medicine taking place? Is it taking place where the patient is located, or is it taking place where the provider is located? And I don't think we've sorted that out.
Yeah.
Yes, and that again, that deals with a revision to the Canada Health Act down the road, because when the Canada Health Act was first written and based on those earlier laws, this was not an issue. It was just assumed that your providers are resident in your province and all your billing arrangements was with physicians resident in your province and with patients that were resident, right? That's no longer true. And we need to revise, I think, the Canada Health Act at some point to reflect that modern reality. It could also benefit certain provinces that have been tremendously underserviced if they could get the benefit of virtual care services from physicians that are based in locales that are overserviced. So it could be actually a more positive outcome if we could figure it out.
So
Yeah.
Greg, is it a revision of the Canada Health Act, or is it an interpretation letter?
I think it would have to be a revision based upon the way in which residency is defined for patients. But you could be right. It could be an interpretation because it's in the provincial machinery that you deal with physicians that are registered in your province.
Yeah.
So it's not a federal law, it's provincial law that's probably more of an issue here.
Yeah, and it gets more complicated again. It's not just interprovincial provision of care. It can and probably will soon be international care. I mean, we already have DA 1300 for nursing advice, and this I think is I don't know if I think it is offshore. I think it comes from outside of Canada. It's a service where you can call a nurse, but I don't think the nurses are in Canada. And I think it'd be quite easy for at least a province to contract physician services offshore much more cheaply. Now, how you'd have to, there's going to be a lot of discussion with the colleges, but it is now something that
Yeah.
can physically be done. So wait and see.
But
Right.
just to end this, though, I would say that it would be very useful in the Canada Health Act in a revision to state that this should revolve around patient care and where the patient is, not around the care itself, where it's sourced from.
Right. I
Now,
mean, the
I think-
essence of, you cited that market capitalization of virtual care slide in the paper, in the report that Will Falk and I and others worked on. And I think the phrase that we used was care is care, irrespective of where or who provides it.
Mhm.
Yeah.
Yeah, no, that's, the only problem is that, when you're dealing with, you still have to have boundaries around that.
Yeah.
In terms of payment, governments need to have certain ways in which to do this that are going to be predictable. So it still, I think, remains a bit of an issue.
Mhm.
Okay. Should we?
So if there are no other questions, I'd just like to say thank you again to Greg and Katherine. Congratulations on such a wonderful book, and thank you for your wonderful presentations. There is a cash bar and snacks at the back of the room, so please join me in celebrating the book.